You doing Thomas first?
That's okay. We can cut it, right? Okay, so we'll start off with the Thomas test first. So the patient will sit on the edge of the table and then lay on back. And you can scooch a little closer to the edge of the table, just where your hips are right off the end. There you go, and then you grab one knee, pull that to your chest. And then the examiner will grab the other leg and guide it down towards the table. This test is going to test for 2 joint versus 1 joint hip flexor tightness, and this is at 0 degrees of abduction. So here you're going to test to see if the rectus is tight. And if the leg is parallel with the table, it's a negative test. If it's raised, it's a positive test. If you extend the knee from here, it should put the quad on slack and test at 1 joint hip flexor of the iliopsoas, and it should drop down a little extra. You can also do the test in 30 degrees of abduction. So you can have them drop down and then move into 30 degrees of abduction to slack the TFL. And from here you can determine if it's just rectus tightness. So if they straighten the leg out and it doesn't drop, there's a pathology with the single joint hip flexor. And in this position, they should get a little extra extension due to the TFL being slacked. Okay, so then we can move into... Alright, so for sign of the buttock as our next test, you'll start with a straight leg raise to rule out any sciatic or neural issues. A positive test would be replication of symptoms, and then from here you'll bend the knee, and if they should get extra hip flexion, so you can push them up, and if they don't, that'd be a positive test, and it would indicate pathology in the hip joint, abscess, bursitis, or neoplasm. So that's sign of the buttock. Okay, from there we can go into FABER test. So put you in the figure 4 position and let that test leg drop down. So it's going to be testing hip capsule anteriorly. So if they're tight and they can't drop down with overpressure, with tested knee and non-tested knee equal, if it's tight up front, that'd indicate tight adductors or anterior capsule. And if they get pain in the back of the hip, it'd indicate compression of that SI joint pathology back there. We can go into FADDIR. So this is flexion, adduction, and internal rotation. So you'll take the testing leg up into flexion, adduction, and internal rotation. This is going to test anterior labral structure. So they would get, a positive test would be a pinch, replication of symptoms, anything up in the front of that hip, because you're just compressing everything up anteriorly in the hip. Okay, so now we'll do the adductor-abductor contracture test. So we'll have the patient bring their feet up and then bridge up in the barstow maneuver and then come back down and then put the feet up naturally. With like an adductor contraction, you'll see this leg stuck out in abduction, and when you go to bring it back to neutral, it'll drop the ipsilateral pelvis. If there is an adductor contraction, you'll see the pelvis stuck, or the femur in adduction, and when you go to bring them back to neutral, it'll hike the ipsilateral pelvis. Okay, for the Obers test, this next one we'll do. So you come up. So we'll get the patients, stabilize the pelvis, end at the knee, sorry. So then we'll bring you into flexion, abduction, and a little external rotation, and then drop you down to the table. And a positive test is when that foot doesn't quite make contact with the table and indicates a tight IT band. And now for the modified Obers, you'll bend the knee, run through the same flexion, abduction, external rotation, and now into adduction. And that's about where she stops. So that would be a positive test. And they should it should have a little less adduction with this version of the test. Piriformis test, we'll have the patient straighten the bottom leg, bend the top leg to about 60 degrees of flexion. And from this position, the piriformis is already on a little bit of a stretch. So then we'll put it on a little extra stretch with the internal rotation. And you can find the piriformis tracing from its origin to its insertion at the greater trochanter and give a little extra pressure. And if this flares them up, it's a positive test for possible piriformis or sciatic issues. Okay. So for Craig's test, you're going to orient the position prone and find the greater trochanter. And from here, you're going to try and determine if the patient has an anteverted hip or not. So you rotate them in IR and ER, feeling as that greater trochanter slides underneath your fingers. And when it's pointing directly laterally, that's where you should stop the leg and measure it with a bubble goni, and it should be between 8 and 15 degrees of internal rotation for a normal hip. And the last test is Eli's test, just to test the rectus. So you'll have the patient prone again, stabilize the pelvis, and from here all you're going to do is flex at the knee and try and bring heel to butt. A positive test would be a hip hike or an anterior pelvic tilt, and she is negative, and that would indicate a tight rectus. For Scour test, we'll have the patient up in hip flexion. This is going to be the test for labral tear. It's going to do Scour and log roll stuff too. Forgot about that. So we'll go into hip flexion, and then you're going to give some compression to the joint, and then move. Going to just scour around through the joint and move into flexion, external rotation, extension, internal rotation. Just trying to find any points that are painful or clicks, and both of those would be a positive finding in the test. And another labral test is the log roll. So in this one, you'll be supine in neutral, or in hip extension, sorry. And then all you're going to do is externally rotate and internally rotate patient's leg. And any catching, popping, clicking, and pain would indicate a labral tear.